Hi there, my name is Mike Pishvaian. I'm an associate professor at Johns Hopkins University, and it's my pleasure today to talk about the relevant updates in GI cancer from ASCO 2023, incorporating some of the data that we've also seen throughout the year. I'm going to talk a little bit about some of the targeted therapies and some of the more practical aspects of caring for patients with GI cancers that have come up in the last roughly 12 months. There were some significant updates in biliary tract cancer at ASCO and ASCO GI in 2023. Most notable, just because it was the most highly anticipated, was unfortunately the negative study SWOG 1815, which was a randomized phase 3 trial of GemCis with or without nab-paclitaxel for patients with advanced biliary tract cancer. We were all very excited because in the phase 2 single-arm trial that was published in JAMA Oncology in 2019, this combination of GemCis and nab-pac resulted in a median overall survival of 19.2 months with a response rate about 65%. So it was a very, very promising combination with really a good scientific foundation. So following on this, the randomized phase 3 study was designed. It included a 2-to-1 randomization for the arm that included the nab-paclitaxel because of the promise of that. And for patients that were enrolled, the intention, the hope was to be able to establish a hazard ratio of 0.7 in favor of the GemCis nab-pac. But unfortunately, as was reported in January by Dr. Shroff, the overall survival and the progression-free survival were no better with the addition of nab-paclitaxel to standard of care gemcitabine and cisplatin. Numerically, they were slightly better, but really these were definitely statistically not significantly better. And unfortunately, it came at the cost of significantly greater adverse events, predominantly GI toxicities as well as myelosuppression. So unfortunately, I think this is no longer something that can be used as standard of care for the patients with newly diagnosed biliary cancer. We do know, however, that immunotherapy has made its way into the realm of first-line treatment for biliary cancer. And GemCis durvalumab is really arguably a standard of care or the standard of care for patients with for newly diagnosed metastatic or advanced biliary tract cancer. This was based on the TOPAZ-1 trial, and it was on a foundation of the idea that GemCis was better than GemCis alone, going all the way back to the Valet study in 2010. So TOPAZ-1 was designed as a randomized phase 3 trial designed to assess whether the addition of durvalumab to gemcitabine cisplatin would actually improve overall survival. It's notable in this TOPAZ-1 study that the gemcitabine cisplatin was stopped in both arms after 8 cycles, or roughly 4.5 months of therapy, 6 months of therapy, despite or irrespective of patient outcome. So if they were actually still responding or had stable disease, you stopped the GemCis, including in the placebo arm. So what was found in the TOPAZ-1 study was that the overall survival with the addition of durvalumab was statistically better than with GemCis alone. It was only a benefit of about 1 month, 12.8 versus 11.5 months, but because it was a relatively large patient study of nearly 700 patients, it did meet statistical significance. And the hazard ratio after 6 months was 0.74. The progression-free survival was also longer, but again, about a month and a half improvement in progression-free survival. The objective response rate was statistically significantly greater with the addition of durvalumab. The one comment that I always make about this objective response rate, though, comparing across studies, which is, of course, completely illegal, is that the objective response rate for GemCis from the Valet study in 2010 was also 26%. So did the GemCis arm underperform in the TOPAZ-1 trial? It's hard to say for sure. The important thing is that I think that the benefit of immunotherapy, of adding immunotherapy to gemcitabine and cisplatin for cholangiocarcinoma, was validated in the Keynote-966 study that was published in April 2023 by Dr. Kate Kelly. This was a very similar trial design, randomized phase 3 trial, patients with newly diagnosed advanced metastatic cholangiocarcinoma. The only difference in this study was that only the cisplatin was held after 8 cycles. The gem was continued in both arms. And I think actually that's a paradigm that I actually feel a little bit more comfortable with, continuing at least the gemcitabine alone in the placebo arm, and certainly in combination with the immune checkpoint inhibitor. And I put together a graph here comparing the two trials side by side, and you can see that the objective response rate with GemCis IO is very, very similar, as is progression-free survival, and the overall survival are almost identical. So I think arguably GemCis IO, whether it's durvalumab or pembrolizumab, has become arguably the new standard of care frontline therapy for advanced cholangiocarcinoma. So where do we go next with this? Well, this is just a teaser of a study that was presented by Anthony Alkhouri in at the 2023 ASCO GI Symposium. This was the IMbrave151 study, and it was a trial asking the question whether the addition of both a VEGF inhibitor as well as a PD-1 or PD-L1 inhibitor could improve outcomes for patients, again, with advanced biliary tract cancers. So in this trial, which was just a randomized phase 2 trial, but not small, 162 patients, patients were treated with gemcitabine cisplatin with atezolizumab and then plus minus bevacizumab. And for this trial, the primary endpoint was progression-free survival, again, with key secondary endpoints. And this trial at least seemed to have achieved its primary endpoint of progression-free survival. The progression-free survival was improved with a hazard ratio of about 0.76. And even the overall survival, which was just a secondary endpoint, seemed to be better with the combination of gem, cis, atezo, bev in this patient population with a hazard ratio of 0.74. When you look at other factors such as response rate, really no significant difference between the two subgroups. So the addition of the the bevacizumab didn't necessarily seem to add a lot there, but certainly disease control rate and other factors as well were similar. So is this going to translate into an overall survival benefit? What's going to have to be done, and I know is in planning, is GemCis atezo with or without bevacizumab as a larger definitive, theoretically registrational randomized phase 3 trial. So stay tuned for those results.